Hey, fellow microbe enthusiasts. Ready for another deep dive?
Always. What fascinating corner of the microbial world are we exploring today?
Well, today we are taking a closer look at a familiar foe, Clostridioides Difficile infection, or CDI for short.
C. diff. Bit of a microbial puzzle, isn't it?
Definitely. It can be pretty tricky, especially for you guys in the lab trying to stay ahead of it.
Absolutely.
To guide us through this, we'll be using the World Health Organization's Aware book, Access, Watch, Reserve, specifically Chapter 33, which is dedicated to CDI.
A great resource.
So before we get lost in the weeds, could you give us a quick and dirty definition of CDI? What is it exactly, and why should a medical microbiologist be particularly concerned about it?
All right, so CBI is an infection of the colon caused by, you guessed it, the bacterium Clostridioides difficile. And it's a big deal for us microbiologists because it often pops up after antibiotic use.
Makes sense.
Yeah, those disrupted gut microbiomes are basically prime real estate for C. diff to move in and cause trouble.
It's like an opportunistic little bugger just waiting for the right moment to strike.
Exactly. And to make it even trickier, we see it in both healthcare settings and in the community.
Speaking of those tricky situations,
Yeah.
what are some signs that a patient might have CDI? What should we be looking out for?
Well, the most common symptom is, of course, diarrhea. We're talking at least 3 loose stools in a day,
Right.
often with cramps and fever.
So those are like the classic CDI calling cards.
Yeah, but here's the catch. Some cases can be much more severe.
Oh, way bad.
Think about a patient with a sky-high white blood cell count, intense abdominal pain, or even organ dysfunction. That's when we really start to worry.
That sounds really serious. And then there's that really scary presentation. Toxic megacolon, right?
Right. Toxic megacolon is rare, but it can be life-threatening. And what's challenging about it is that it might not even present with diarrhea, which can make diagnosis tricky.
So much for those classic symptoms.
Right.
Okay, so let's move on to the lab where you guys work your magic. Diagnosing CDI can feel like solving a mystery sometimes. What are the lab tests that you find the most useful for figuring out if a patient has CDI, and what are some of the things we need to keep in mind when we're interpreting those results?
So there's no single perfect test, which is part of the challenge.
I figured.
A lot of labs use a two-pronged approach. Some start with a highly sensitive test, like NET, to see if C. difficile DNA is present.
Okay.
And if it's positive, they'll follow up with the toxin test, like the toxin ABEIA, to confirm if the bacteria are actually producing toxins.
So it's a two-step process.
Exactly. Other labs will run a GDH antigen test and the toxin ABEIA at the same time.
Got it. But I bet there were some nuances to interpreting these test results that a savvy medical microbiologist needs to be aware of.
You bet. Take NET, for example. We might get a positive result even if the bacteria aren't actually producing toxins,
Oh, interesting.
which could lead to overdiagnosis. On the other hand, the toxin ABEIA might miss some cases because it's not as sensitive as NET.
So it's a bit of a balancing act. What about the GDH antigen test?
GDH is very sensitive, but it can't tell the difference between toxigenic and non-toxigenic strains.
So it's not perfect either.
It's all about choosing the right tests based on the situation and knowing what the results really mean. And sometimes we have to look beyond just those initial tests, especially in those severe cases. We might need to order a complete blood count or check electrolyte and creatinine levels to get a better picture of what's happening with the patient.
Speaking of tests, the WHO Aware book we talked about has a handy table, Table 33.1, that outlines various microbiology tests used for CDI diagnosis. Could you give us a brief rundown of those?
Sure. It covers the big ones like culture and NATAT, as well as the GDH antigen test and toxin assays.
Okay.
They each have their own quirks and advantages.
Give us an example.
Well, culture is considered the gold standard for identifying the specific strain of C. diff.
Right.
But it takes longer to get results. Ultimately, the choice of test depends on what your lab has available and what your local protocols are.
So it's like picking the right tool for the job.
Exactly.
Now, what about imaging? Does that play a significant role in diagnosing CDI?
We don't usually jump to imaging like an abdominal CT scan right away. It's more for when we suspect complications like toxic megacolon or a bowel perforation.
So it's more about ruling out those worst-case scenarios or confirming what you already suspect, especially when the clinical presentation isn't clear-cut.
Exactly. It gives us a better visual of what's happening internally when things get complicated.
Okay, so we've talked about diagnosing CDI. What about treating it? Where do we even begin, and what does the WHO recommend for a first episode?
The first thing we need to do is stop any unnecessary antibiotics the patient might be taking.
Right, because that disrupted gut microbiome is what gave C. diff the opportunity to take hold in the first place.
Exactly. And we need to make sure the patient is well hydrated, especially with all that diarrhea they are experiencing.
So it's back to basics. Restore balance and support the patient's overall well-being.
Absolutely. Now, when it comes to our first episode of CDI, the WHO recommends metronidazole as the first-line treatment. The typical dose for adults is 500 milligrams orally every 8 hours.
And for kids?
For kids, it's based on weight. 7.5 milligrams per kilogram, also given orally every 8 hours.
What if metronidazole isn't doing the trick? Or if the CDI is more severe, what's our next move?
If metronidazole isn't enough, or the case is more serious, we turn to oral vancomycin.
Right.
The usual dose for adults is 125 milligrams every 6 hours. For children, it's 5 to 10 milligrams per kilogram, given every 6 hours. And for those really severe fulminant cases, we might even combine oral vancomycin with intravenous metronidazole.
So we have options, but choosing the right one depends on the individual patient and how severe their CDI is.
Precisely. There's no one-size-fits-all approach here.
So how long do we typically give these antibiotics for a first episode of CDI?
The WHO guidelines recommend treating for 10 days.
10 days. Got it. Okay. Before we jump into the fascinating world of how C. diff actually causes all this trouble, how about a little quiz to test your knowledge?
Let's do it.
All right. First question. What is the most common symptom of Clostridioides difficile infection?
That's an easy one. Diarrhea.
That's right. Question 2. What is the first-line antibiotic treatment for a first episode of mild to moderate CDI in adults?
Metronidazole. It's usually our go-to choice.
You got it. Third question. How long do we typically treat a first episode of CDI with antibiotics?
10 days. We just covered that.
That's right. You're on a roll. Okay, true or false? All strains of C. difficile produce toxins.
False. Not all strains produce toxins.
You are correct. We've got both toxigenic and non-toxigenic strains. Okay, last question. Which of these is not a risk factor for CDI? Age 65 or older, recent antibiotic use, previous hospital admission, or consumption of probiotics?
That would have to be consumption of probiotics.
Right again. You aced the quiz. It seems like you've got a good grasp of the basics.
Well, I try to keep my microbial knowledge up to date.
Well, we appreciate that. Now, I think it's time to delve into the intriguing world of C. diff's pathophysiology. How does this bug actually do its dirty work in the gut?
Get ready for some microbial mysteries. It all starts with those hardy spores.
Now, this is where things get really interesting. Tell us all about it.
So, are you ready to uncover how these tiny C. diff spores can cause such a big ruckus in the gut?
Absolutely. I'm especially intrigued by how this bug can have such a huge impact, not just on individual patients, but on entire healthcare systems.
Yeah, it's a good reminder that we're not just dealing with a clinical problem, but a public health issue.
For sure, and one with significant economic implications too, right?
Absolutely. The WHO's Aware book really hits on that point.
Okay, so let's talk about those wider ramifications for a bit. How does CDI actually strain healthcare resources? It's got to be more than just the cost of the antibiotics.
Oh, definitely. Think about it. Longer hospital stays, isolation precautions, potentially even intensive care, it all adds up. And when you consider how common CDI is, especially in healthcare settings, the costs can be massive.
Billions of dollars annually, if I remember correctly.
Oh, you got it.
It really emphasizes how important prevention is. But when CDI does happen, are there any promising new treatments on the horizon besides the antibiotics we talked about?
There's definitely some exciting research happening. One approach that's getting a lot of attention is fecal microbiota transplantation, or FMT for short.
I've heard of FMT. It's kind of like a microbial makeover for the gut, right?
That's a great way to put it. The idea is to repopulate the gut with a healthy mix of bacteria from a donor. And it's been incredibly effective, especially for those stubborn, recurrent cases of CDI that just don't respond to antibiotics.
Yeah, the cure rates are impressive. Over 80% in some studies. So is FMT becoming the new standard of care for CDI?
Not quite yet. There are still some kinks to work out, like how to standardize the procedures, screen donors, and make sure it's safe in the long run. And then there's that, ick factor that some people might have a hard time getting past.
I get it. But with those high cure rates, it seems like FMT could be a real game changer. Are there any other new treatment strategies being explored?
Oh, definitely. Researchers are looking for ways to target C. diff more directly without harming those good bacteria in the gut. New antibiotics are being developed, and there's growing interest in using monoclonal antibodies to neutralize the toxins that C. diff produces.
Monoclonal antibodies. They're showing promise for other infections, but how would they work against CDI?
Think of them as tiny little assassins that zero in on the toxins. They bind to those toxins and block them from damaging the colon. Early research suggests they might be useful for both preventing and treating recurrent CDI.
So we're moving away from that carpet bombing approach of traditional antibiotics to a more targeted strategy that takes the whole gut microbiota into account.
Absolutely. And what's really exciting is that this research isn't just leading to new treatment options, but is giving us a much deeper understanding of the gut microbiome and its role in health and disease overall.
It's like we're peeling back the layers of this incredible ecosystem in our gut, one microbe at a time. Okay, before we move on to preventing CDI, how about another round of those quick-fire questions? Ready for round two?
Bring it on.
All right, first question. How does FMT actually work against recurrent CDI? What's the main mechanism?
Well, FMT basically restores a healthy, diverse community of bacteria in the gut. This helps outcompete and suppress that troublesome C. diff.
Excellent. Next question. True or false, monoclonal antibodies actually kill C. diff bacteria?
False. They're more about neutralizing the toxins, not the bacteria itself.
Gotcha. So disarming the enemy, not wiping it out completely.
Precisely.
Yep. Next one. What's a key advantage of FMT over traditional antibiotics for those stubborn recurrent CDI cases? Is it lower cost, reduced risk of recurrence, easier administration, or fewer side effects?
The big win for FMT is definitely the reduced risk of recurrence. By addressing the underlying dysbiosis in the gut, it makes it much harder for C. diff to make a comeback.
Makes sense. Okay, here's a tricky one. What's a potential challenge with FMT? Lack of efficacy, high cost, difficulty finding donors, or all of the above?
Oh, I'd say it's all of the above. FMT is still pretty new, and there's a lot we're still figuring out, like standardizing procedures, making sure donors are safe. It's a work in progress.
And last but not least, which of these is not a current area of research for CDI treatments? Development of new antibiotics, use of monoclonal antibodies, fecal microbiota transplantation, or gene editing of C. diff?
That would have to be gene editing of C. diff. It's a fascinating field, but not something being actively explored for treating CDI right now. The other three are definitely hot areas of research.
You're a CDI whiz. Seems like you've soaked up all this info like a sponge.
Always eager to learn more about the microbial world.
That's the spirit. Now let's shift gears and talk about preventing CDI, focusing on antibiotic stewardship and infection control.
This is where it all comes together, and where you, as a medical microbiologist, play such an important role.
Absolutely. So let's jump in and see how we can work together to keep this pesky bug at bay. So let's talk about those two main strategies for preventing CDI, antibiotic stewardship, and infection control. And these are areas where you, our listeners out there in the microbiology labs, play a really vital role.
I totally agree. It's about more than just following protocols. It's about changing the way we think about antibiotics, protecting them, and protecting our patients.
So antibiotic stewardship, it sounds pretty straightforward, right? Use antibiotics wisely. But I bet it's a lot more complicated in practice. What are some of the challenges you encounter when it comes to antibiotic stewardship?
Oh yeah, there are definitely challenges. Sometimes it's hard to tell if an infection is caused by bacteria or virus, and there's always pressure, from patients and even sometimes from colleagues to prescribe antibiotics just in case. It can be tough to resist that urge.
So it's about being a guardian of those antibiotics, making sure they're only used when they're really needed. And that's where you guys, the microbiologists, come in, right? Helping clinicians make those informed decisions about antibiotic use.
Exactly. We're like the detectives of the microbial world. We identify the culprits, figure out what they're susceptible to. Our insights are so important for guiding appropriate antibiotic use.
It's a team effort for sure. Clinicians, pharmacists, microbiologists, even the patients themselves. We all have a role to play.
Absolutely. And speaking of teamwork, let's talk about infection control. Those C. diff spores are incredibly tough.
Yeah.
How do we prevent them from spreading in a healthcare setting?
Yeah, it's like we're waging war against this invisible enemy. What are our best weapons in this fight?
Well, the first line of defense is, and always will be, good old-fashioned hand hygiene.
It's so basic, but so important.
Washing hands with soap and water, or using an alcohol-based sanitizer before and after every patient contact, especially those with CDI.
You can never emphasize hand washing enough.
You're absolutely right. But it's not just about hand hygiene. Environmental disinfection is also crucial. We need to be vigilant about wiping down high-touch surfaces in patient rooms, bathrooms, common areas, using those EPA-approved disinfectants that can actually kill those C. diff spores.
So we're talking about some serious cleaning here, not just a quick wipe with a damp cloth.
Exactly. And let's not forget about contact precautions for patients with CDI. Gloves, gowns, proper disposal of contaminated materials. These are essential barriers to preventing the spread of those spores. And sometimes we need to isolate patients or group them together in a cohort to further limit the spread.
So it's a multi-pronged approach.
Yeah.
Antibiotic stewardship, hand hygiene, environmental disinfection, and appropriate isolation precautions.
Yeah.
It takes a coordinated effort from everyone to keep C. diff under control.
You got it. And this goes for everyone entering the hospital, healthcare workers, visitors, even the patients themselves. We all have a responsibility to prevent the spread of CDI.
Okay, so we've covered a lot of ground today, from those basic diagnostic tests to the complexities of how C. diff causes disease, who's at risk, and how we can treat and prevent CDI. It's been a real deep dive into the world of this challenging pathogen.
And we've highlighted the incredible work that you, our medical microbiologist listeners, do every day to combat this tricky bug.
To all of you out there, keep up the great work. Keep those lab coats on, those microscopes focused, and keep asking those important questions. Because by working together, we can outsmart this pathogen and improve the lives of our patients. And to our listeners, thank you for joining us on this deep dive into the world of Clostridioides Difficile.
It's been a pleasure exploring the microbial world with you.
Until next time, stay curious.